Hello everyone, welcome to The Voice of Nursing. My name is Adrian Tracy, I'm the CEO of ICG Medical. Delighted today to be joined by Roy Lilley, former NHS chairman and the founder of NHS Fab Stuff. Welcome, Roy.
Thank you very much, Adrian.
Roy, lovely to have you here. I know you've had an extensive career, to say the least. Be great to get a bit of an understanding of your background and how you got involved with the NHS.
Well, it's a kind of long story. I mean, my background is in business. I'm not a clinician at all, and I came into the health service pretty much by accident. I was a counsellor in where I live. I live in Surrey, and I was a counsellor there, and I went on to become the leader of the council and the mayor. And but in my early part of my career as a counsellor, I was the chairman of the Health and Housing Committee. Now, the Health and Housing Committee in those days was all about council houses and the allocation of council houses and the repairs and maintenance of it. It was a nightmare job. I mean, now most of the council houses are looked after by housing associations, and it's a lot better. But those in the days when councils did it. So I did that, and the health bit, the health and housing bit, the health was tagged on. And I didn't really know what that meant anyway, but I discovered it gave me a seat on the District Health Authority, right? Like I needed another job. So I went to the District Health Authority as the representative of my council. And it was a nightmare. I mean, it just kind of blew my mind. Yeah, all the abbreviations and the whole accounting process, and it was like I'd landed on Mars. You know, it was a completely foreign language. But do you know what? I really enjoyed it, and I got into the finances, and I could see, you know, we were heading for a disaster. When is the NHS not heading for a financial disaster? But so anyway, after a cut a long story short, I ended up the vice chairman and finally the chairman of the health authority. And it started to consume me more than being a counsellor, because I felt I could really do things. You know, it was about running hospital. I mean, in those days, the health authority had a much more hands-on role than they do now, and I had special responsibility for the hospital. Then other people did the community services and all the rest of it, and it was all a big disjointed mess run on tums. You know, it's like the NHS still is today, I think. But I really enjoyed it, and as a result of that, I then became the chairman of one of the first ever NHS trusts, back that part of the Thatcher reforms. And so I was there chairing my fiefdom. And it was so that's really how I became involved. And I became seduced by its significance. I became completely mesmerised by the challenges with staffing and training and the sheer size of everything. And then I helped to start an organisation called the Federation of NHS Trusts, which is now the Confederation. But I started that with a couple of other chairmen. And so we had a voice for the trusts, and then we had regular contact with the ministers. And then I became the chairman of the National Standing Committee on Supplies and Purchasing, which is all about buying bog rolls and all that. And it was a complete mess when I ran it. And I'm pleased to say I think NHS procurement is still a complete mess today. We still can't manage to buy cheap bog rolls. But procurement is a very complicated thing. And then I moved on from that to the National Standing Committee on Human Resources, and that was about it was very early days of 2P and designing some of that, and then I got involved in health policy at a national level. I went on to become a policy advisor, and then I helped to start the Health Services Management School at Nottingham University, and then I came down to London. I was a visiting fellow at Imperial College, and I went from there really. But so it was a career of no great design or direction. It was a career of serendipity and being sucked in by something that I thought was really interesting.
I think you've been pretty humble there, Roy, if you don't mind me saying.
Really, I mean, I just got more and more sucked into. I'm thinking, what am I doing? Yeah, I didn't know what I was doing.
And take us up to present day.
Well, I'm 73 now, and I've retired 3 times. You know, I retired first when I was was 55, I sold my businesses and retired. And then I started another business and sold that and retired. And then I was looking around for things to do and what have you. And well, the story, I mean, what this does is lead me to today, to the Academy of Fabulous Stuff. And the story of that is simply this, that I was speaking at a conference one day, and in the news on that day, there was a trust that had got itself into trouble over targets on chemotherapy. And there are certain timelines with chemotherapy that people have to have their treatment because it's very important. I think it's 35 weeks or 64 or whatever. Anyway, people watching this will know what the targets are. But this particular hospital had breached the targets, and 3 people had died. We don't know whether they died because they were very sick and they would have died anyway, or they died because they didn't get the chemotherapy. I mean, I guess we don't know. But the police were involved. The chairman stood down. The chief executive walked. I mean, he wasn't culpable. He was responsible. You know, it's the usual story. And I said at this conference, you know, what happened? Well, what happened was they were due to have a visit from the CQC, and frankly, they lied about what happened. They falsified the documents. They falsified the register, and they said people had had chemotherapy when they hadn't. And I just couldn't understand how do we manage to turn good, honest, hard-working people with a career, a qualifications, a strong sense of vocation, how did we manage to turn them into crooks and liars? And it was because they were frightened of the CQC. They were frightened of the regulator. They were more frightened of the regulator than the relatives and families and friends of the patients who died. And of course, you know, anyone who knows anything about management knows that inspection is absolutely the wrong thing that you do to try and improve quality. If you go back as far as Edwards Deming, who's the godfather of management gurus in the 1960s, he has his 14 points of management. They're really worth, you can still Google them today, Deming's 14 points of management. Number 3, don't rely on inspection as a way of improving quality. You can't. You have to build quality in, total quality systems, so you can't inspect it. And what inspection did was frighten everybody. So they thought they were doing the right thing by keeping the trust out of trouble by, you know, and anyway, it was all horrendous. So I said at this conference, wouldn't it be much better if we had something like, I don't know, the Academy of Fabulous Stuff, where people could ring up and say, hi, we got a real problem with chemotherapy. Has anybody else got the same problem with chemotherapy? And someone would spin a Rolodex, you know, if you remember what a Rolodex is, spin the Rolodex and say, yeah, there are 3 hospitals, you know, that have had that problem. Ring them up and they'll tell you how to resolve the problem. Wouldn't it be good if we could do that? As it is, we frighten everybody with this. And I got off the stage and someone came up to me and they said, you know what, why don't you do that? It'd be a great idea. And I said, what? He said, well, the Academy of Fabulous Stuff. And I said, really? You think it's got legs? He said, absolutely. There is no repository of best practice in the NHS. So, several £1,000s later, I started the Academy of Fabulous Stuff. I met Dr. Terry Lannis, who I think has appeared on your program, and together we started the Academy. And it's a very simple thing. If you're doing something you're proud of, or it's a good idea, or you've solved a problem, give us 300 words on it, 3 photographs if you've got them, and as many links as you like, and we'll put it on the Academy. And so we started the Academy of Fabulous Stuff with no ideas, no one knew what we were doing, and an empty repository. And within a year, we were getting like 2,000 page views a day. We were getting like 50 ideas a week. You know, and now we're nearly 4 years old. We get 3 million page views a year. We've been to Canada to get it started there, and Australia. They're going to do it there as well. So, and it's become the repository of best practice. And we have ambassadors now that are with us, and they represent us in the hospitals. yesterday we had our annual awards. So I'm really quite proud of what's happened out of a chance remark at a conference. It's taught me to be a lot more circumspect about what I say at conferences. But it's been huge, and people love it, and I'm just very pleased to be able to do it.
That's a great organisation sharing best practice, and it's improving patient care.
It is, and it's a morale thing as well. People get very proud of their staff, and we have a saying. We say there's no such thing as a small thing, because a small thing is a big thing to somebody. Mm-hmm. It's a big thing to someone in a bed who's worried and frightened. It's a big thing to someone how they're employed and their conditions and terms. It's a big thing to whoever it is that's involved. So there's no such thing as a small thing. What I've learned, I've been in and around the health service for 40 years now. I came to work with Florence Nightingale on the number 17 bus. Oh, people think I did. People are convinced I knew Anna Bevan. I've been around for so long. But what I've learned is that I have wasted my entire career in the health service. I've been involved with all of the major reforms. I was here for the Griffiths report when Roy Griffiths said if Florence Nightingale was alive today, she'd wander around the corridors of our hospitals asking who's in charge. And he introduced management, general management. We had the Thatcher reforms that I was very much a part of. We had Tony Blair's market reforms with competition, things like that was introduced. Now, and then we've had the lunacy that's Andrew Lansley's reforms that we're still trying to scrape off our shoes and sort out.
I was going to say, we'll ask you about the Health and Social Care Act.
Yeah, well, I hope you got a lot of film. And I've realised, that you can't do anything top down. I used to think you could, and I've been part of all of that. But it's only really in the last 4 or 5 years that I've realised that the only way you change things is on the ground. If there's a problem somewhere, someone will have a solution. And if there isn't a solution, if you ask people doing the job, you say, okay, what do we got to do to fix this? They'll tell you. But we don't. We sit in Whitehall, we write guidance which is meaningless, we do edicts that never reach the front line. I spend a lot of time in the front line, and I say to people, have you seen the latest guidance on so-and-so? They say, no. It doesn't reach the front line. And so it's our job to reach the front line. And Tom Peters, in his management book, In Pursuit of Excellence, he talks about management by walking about. And, if I had my way, I would burn managers' desks, and I'd make them walk around the places they're managing. You can't manage anything unless you're in it. I say you can't manage anything if you can't smell it. You have to be able to describe the smell of the places that you run, and people can't. And so that's really how I'm convinced myself that I've wasted my last 40 years. So in my next 40 years,
moving forward,
I'm going to start from the ground floor up, and that it works. It absolutely works. If you go to anywhere and you say to people, okay, what 3 things would you change? What 2 things would you change? With money from the petty cash tin, what would you change? And they'll say, well, it'd be a lot easier if we had this or that or this, And you say, well, we can do that. Why wouldn't you listen to the people doing the job? But we don't. Nursing, it's becoming more and more of a challenging job, and we say, we must improve nursing. And the RCN will produce a document, and the Health Education England will produce a document, and the Secretary of State will produce a document. The one thing we don't do is to go on the wards and say, this is a tough old job, how can we make it easier?
Yeah, I think, nurses, are under more pressure than they've ever been. They're getting stretched, lack of breaks, chance even to go to the toilet or eat. Yeah. And they're under so much pressure at the moment, and the mental health of nurses is a really big thing.
You're absolutely right. And I am fearful for the profession of nursing. And I think nursing has to change. Now, when I say that, I'm not prescriptive, and I'm not quite sure what I mean. But let me explain my thinking. I mean, I'm nursing's biggest fan, right? I'm the chairman of their fan club, I'm the cheerleader for nursing, and we all know the pivotal role that nurses play, and I've seen nurses develop. I remember going to an awards ceremony in Germany, the Golden Helix Award it was called, and it was in the mid-80s, and we went there, and I met a nurse nephrologist, right? Back in the mid-80s. Now, first of all, I didn't know what nephrology was, and secondly, I couldn't see how you can have a nurse nephrologist. But of course, it was the very start of the specialist nurses, and they started in Europe, and we were very late to adopt specialist nursing. And I remember when we first did prescribing, nurse prescribing, the BMA said that nurses would kill people if they prescribed. You see, and I remember saying, "Yeah, well, you mean like doctors do? Let's face it, you're pretty good at killing people as well." I had this big row with the BMA, but so I've seen the developments in nursing, and I've seen them develop their skills in nursing. Now I'm worried, and I tell you why I'm worried. There's two reasons, really. The first reason is the way we train nurses. Now, there are 17 nurse schools, where you can train to be a nurse, and there are 17 curriculums. There isn't a standard national core curriculum. I think, what do I know? I'm not a nurse, but it seems sensible to me that we train nurses on a central core curriculum. Now, the argument is, we're training local nurses to fit into whatever the local hospitals want. I tell you what the hospitals want. Hospitals want trained, competent, confident nurses to come on the ward when they've qualified. And a lot of hospitals tell me they have to start retraining the nurses when they arrive, fit to practice. So it's about a central core curriculum. And for example, there is no module in the nurse curriculum about prescribing. Now, I'm not saying every nurse needs to come out of university as a prescriber, but I do think they could do the foundation course, because when they get on the ward and they want to be a prescriber, it takes years for them to do it. And we could prepare that ground, because it's obvious to me nurses are going to have to play a bigger role in the care of patients, and a bigger role will involve prescribing. So that's the kind of thing when I say nursing needs to change. We need to think about that. We need to think carefully about what's the pathway into nursing. Now, there's an argument about whether or not all nurses should be degree courses, and I'm not going to get into that, because I think I want nurses at least as well qualified as the girl on the checkout at Sainsbury's, because everybody's got a degree. So I'm not going to get into that, but I do think there is a thing about the pathway into nursing. Does it have to be done on a university basis, or can we come onto the ward and train on some kind of other basis? Now, we're just starting to do that. We've got the apprenticeship scheme, which I think is a great thing. Now, I know a lot of the nurse academics don't like it, and it's, there's a whole argument about it, but it just seems to me sensible that for nurses who perhaps are not academic and haven't seen themselves going to university, or perhaps because of their home circumstances or what have you, they can't do it that way, we ought to have another way of doing it. And the apprenticeship scheme, I think, is great. You still get a degree. It takes longer, but you work while you earn and while you learn. Now, I think that's a good idea. The trouble is, last year, only 240 nurse apprentices came on, and I think we need to do a big push for that. Why? Because we have 50,000 vacancies in nursing now. There was a report that came out, I think, yesterday from the King's Fund and the Nuffield Trust and everybody, all the sort of big knobby brain boxes combined, and they all produced this report that said, guess what? We haven't got enough nurses. Guess what? It's worse than we thought. There are 50,000 vacancies now, and I think by 2050 or something, they're saying there's going to be like 300,000 short. I mean, it's a horrendous figure. And unless we do something about that, one, to make the curriculum more meaningful in terms of what the nurse of the future looks like. Two, we make the pathway into nursing more realistic for more people. And three, this is my other big point about nursing, is it's a hell of a job. It is a hell of a job. Now, nurses I'm told nurses like to compress what they do, so you get 3 12-hour days back to back. Now, I don't know about you, but 3 12-hour days on your feet, scurrying around all day, under a lot of pressure, making very important decisions, I think you're just zombied at the end of that.
Yeah, I think there's also an element of, a lot of nurses don't stop at the 12-hour. If they've got a patient, they'll carry, I've had that as a personal experience with a midwife delivering my first child, and the midwife stayed for like another 6-7 hours looking after my wife at the time. Nurses don't clock in, clock out.
They don't.
They wait, they look, because they're caring for that patient.
They don't. And the other thing is this, that they only earn, 23,000, I think, when they start. So what do? They do their 3 shifts back to back, and then they do a couple of shifts in a care home. And so, if you think about it, an airline pilot can only fly, I think it's 2,000 hours a year. A lorry driver can only drive for 9 hours a day. And now they're going to stop the Uber drivers from driving 12 hours a day, but the nurses, they can work until they drop. It's not safe.
No, and I suppose then mistakes happen. We're all human.
There's 1 million people being looked after in the NHS whilst we record this. And we can't kid each other, can we, that 1 million people, some of that million are going to come unstuck. And of course, tiredness and pressure is a big part of when people make mistakes. So what I'm saying, I think, is we need to think about how we treat nurses as employees. Now, there are some great male nurses, and thanks guys for doing it. It's a great job for men. Let me just get that out of the way. But it's largely a female occupation. Women are principally carers. They bear the burden of families, and they are principally, these days now, people who earn a principal wage in many instances. And we look after more women than men, because women live longer than men, and carers are generally women. And the question is the NHS woman-friendly? Is it woman, and for nurses, is it female-friendly? Is it family-friendly? How many hospitals have a creche? How many hospitals think about their policies to make their employment female family friendly? We don't do that. I think I can think of one that has, but I can't think of it now. What does that mean? What does female family friendly mean as an employer? The answer is I don't know, because I'm not going to fall into the trap of saying this is female friendly. This is how you do it. Because what I believe now is you go to the hospitals and you say, how do we make this place female family friendly? Go
and ask the front line again. What do they need? Is it different hours? Is it a creche, or is it support? Is it whatever? It
may well be that it is 3 hours, 3 shifts back to back. But maybe we say, well, okay, but it does mean that you don't go and work somewhere else for another 8 hours. How do we manage the salaries of nurses? And let's face it, the nurses didn't have a decent pay rise for 8 years. So they've lost 14% of their income's real value. Now, okay, there's an austerity argument. We understand why that is. It doesn't make it right, but I'm not by saying we understand it. I'm not saying I endorse it, but I do understand that, and the government's anxiety about incomes and austerity. But you can't expect people to come to work with a joyous heart if they're being paid 14% in real terms, less than they should be.
Yeah, it's vocational as well, but that'll only extend so far. Especially with no bursary. Mature students probably can't even look at that as an option now. Whereas sometimes it's a second career is nursing.
The bursary is really interesting because when the bursary was around, for every single nursing place in university, there were 5 applicants. We were oversubscribed. Now the bursary's gone, it's dropped down to 3 applications for every place, and the trajectory is downwards. Now, nurses were in the unique position of having their degree courses paid for, and I can't think of anything else. Unless you're sponsored, that was pretty unique. I can't think of anybody else who gets their bursary, gets their education paid for. And the government's view was, and I get this, the government was saying, look, we can only afford a certain amount of bursaries, and that's the choke point, because we are determining the number of places that there are to train nurses. We need more nurses. What do we do about the choke point? And I had a lot of discussions with Jeremy Hunt about that. He was very frank about it, and he thought very carefully about it. I mean, he was portrayed as the villain of the piece, but the logic was, if they take the bursary away and put nursing on the same basis as every other degree, there will be no choke point. And the universities will be able to offer as many nursing places as they could fill. So we wouldn't have the choke point. And then the argument then was, well, if you put nurses on the same basis as every other student, they'll pay back on the same basis. And actually, a nurse coming into profession, having first qualified, wouldn't pay anything back because they were under the threshold limit of when the repayment started. That isn't to say that they wouldn't over the lifetime, but it's not a loan, so it doesn't distort your credit rating for a mortgage or any of that. So, I mean, I kind of understand why the government thought like that. They thought if they took that pinch point away, the universities could offer as many people, because they were on the thinking. They were thinking, look, if there are 5 applications for every one place, if we create more places, we can train all the 5 nurses. So that was the thinking. Of course, like the best intention, it didn't work, because there were concerns about student loans, which I think were misrepresented, but there were concerns about student loans. The austerity was having a terrible effect on wages and status, and at the same time, the downward pressure on the number of nurses there were in the profession had started to take effect. You can't take 50,000 people out of the workforce and not feel it. So the pressure on the wards got worse and worse, and now I fear that whilst nursing, people come into nursing because they have a strong sense of vocation and want to do it, I'm starting to fear that they may have a strong sense of vocation, they may want to do it, but they may want a mortgage and a family and all the other things in life as well. And just maybe, I don't know, but we need to think about this, just maybe nursing becomes a second choice rather than a first choice. And it's a pity, because it's a fabulous career. It opens the doors to all kinds of things. You have a real career path in nursing. You can do nursing in management. You can be a nurse on a cruise ship and travel the world, or you can be in A&E, and it's just like Holby City, like with knobs on. You know, it's all of that. Nursing is everything. I think it's a wonderful profession, but it's a profession that's under huge pressure.
Yeah, I think it's as varied as you want it to be. Some of the nurses, they've had kind of 3 or 4 different careers within nursing, like on specialist or management, as you say, or chief nursing officers.
Well, look at Terry, Dr. Terry Porritt, who you interviewed. I mean, she came on the ward as a nurse. She became a specialist nurse. She got a doctorate in nursing. She's written textbooks on it, and now she's the head of education for Coloplast, and she runs the Academy of Fabulous Staff. She couldn't do it unless she was a nurse. And yesterday I was with Jane Cummings at an event, and I mean, if you look at Jane's, she started as a nurse, on a ward like everybody else, and she ended up chief nurse. She's got management qualifications. She's been running nursing, and she was running London at one point as well. So it is a wonderful career.
Yeah, I love Terry, when she did her interview, she introduced herself as a specialist nurse. Yeah. And Donna Kinnair at the RCN, I'm a nurse. Yes. That's where they start. Yeah. Whatever else kind of comes with it.
I know, once a nurse, always a nurse.
I agree. What sort of or what trends should we be watching for, do you think, over the next couple of years in nursing?
With nursing, well, I mean, I rather hope that my messages won't fall on deaf ears, and I rather hope there'll be a rethink at Health Education England. Health Education England is the arm's length body that's responsible for education in the NHS. They've had a pretty rough ride, really. They were no sooner formed than they had their budget cut by 9%, and they've since had their budget cut twice. So, as much as I do give the Health Education England some stick, they were dealt a really bad hand. They've now come under the auspices of NHS Improvement, and I think moving them closer together to the operational side of the NHS, I think that will be good, rather than them being at arm's length. I understand why they were set up at an arm's length, but I think they are better closer to the operational aspects. So if I look at the future, well, almost certainly we're going to look to nurses to take on more of the repertoire of the medical aspects of looking after people, and why not? Absolutely, why not? And I think there'll be that's what we touched on earlier. There's a rich vein in nursing where you can, if you want to be a nurse on a ward and be a staff nurse and run a ward and hands-on and have care for people, you can do it, and thank goodness people do, and it's a great career, and you can progress with that. But I think we're now moving into greater specialisms. My worry is that people will move into specialisms at the expense of general nursing, and that's why I think it's very important that we make general nursing as attractive as a career opportunity as we can. And then, of course, there's the impact of technology. Who knows where that's going to take us? At the moment, the NHS is like an electronic Tower of Babel. We've got loads of kit that doesn't talk to each other and no idea how to make it talk to each other. And on the other hand, we've got a whole load of bobble-at people turning up with apps that we think it's a great app. It's an app to manage bunions, or an app to manage tennis elbow, or an app to manage a heart attack. We've got nowhere to plug all this lot in. Yeah. So, we're reinventing the electronic Tower of Babel, but certainly the digital nurse is the nurse of the future.
Yeah, because technology's having a massive impact, isn't it? But as you say, I think as you rightly say, it's the implementation. Yeah. And it's about, you can have the best apps in the world, but if people don't use them.
No, well, we've got such a mess. We've got NHS Digital, who collates and counts the numbers, and I don't know. I mean, if they're watching this, they're going to hate me. But I mean, I have no idea what their strategy is for the future of digital health service. NHSI, they've got a head of digital. NHSE, they've got a head of digital. And if you put the D for the Department of Health together, and the I for improvement together, and E for NHS England, you spell die. We've got NHS die, and we're going to die under a great welter of stuff that we can't connect. And yet the public are ahead of us. I mean, if you think about Babylon, which is the free app that you can get through signing on with a GP. I mean, there's a whole other program to do about Babylon. But the fact that 70,000 people have said, "I want it." Yeah. The public are ahead of us. They order their stuff on Amazon, but you still have to traipse down the road from the doctor with a piece of paper to Boots the chemist and be told, "We haven't got it for 20 minutes, will you come back?" Why don't we do it on Amazon?
Well, I think that's what they're doing in America.
Yeah, why didn't the GP do a prescription and send it to Amazon and I have it delivered to my desk that afternoon? There's all of that. And you know what? It will come. There was a time when you talked about technology and you sounded like you're away with the fairies, but actually no, because it's happening now. And I think the public will say, really, come on, wake up, guys.
You're leading that charge with the NHS Managers Network in your weekly newsletter?
Well, it's a daily. Yeah, it's a daily. Yes, I started it with 25 readers. I now have 300,000 a week reading it. Yes, it's a kind of daily moan about stuff, or it's a daily praise about stuff, or it's whatever comes into my mind as a topic. Sometimes I'm guided by a news and events. Sometimes I've just been thinking about management. I'm interested in the theoretical aspects of management, and so I write about all of that kind of stuff.
And is there any feedback from that management network that challenges they're facing?
Yeah.
Because there's different opinions as well.
Since I started, I now get 300 emails a day, and which I'm always very pleased to have. Don't stop writing. Thank you. And I try to answer as many as I can. And people are great. Yeah, I mean, they share their stuff. They give me ideas. They tell me when I'm wrong. They don't hold back from that, and they tell me when they find a spelling mistake, and they give me some stick. But it's a great conversation I have with the NHS every day.
And in regards to the healthcare service, as we were corrected by an MP earlier in the week, how changes in that healthcare service can affect clinical practice, do you think?
I mean, people say the NHS has to change, right? So I always say to them, well, what do you want to change? It's widely regarded as one of the best systems in the world. Young or old, rich or poor, granny or drug addict will turn up, pick you up, get you back up on your feet as fast as we can and get you home. We can. And no credit card required. You know, what exactly do you want to change? And because it's about the money, really. The NHS, you see, between 1948, which is when the NHS was born, we're celebrating its 70th birthday this year, between 1948 and 2010, the average uplift in funding in that period, it goes up and down, but the average is 4%. 4% funding. From 2010, when we had austerity, the world banking crisis, the government did a handbrake turn on all of the expenditure. Between 2010 and today, the average uplift in funding is under 2%. Now, we've got some new money coming into the system in April next year. This much discussed £20 billion that the NHS is going to have. Actually, in the first year, it's a 2.9% uplift. And in subsequent years, it's about 3.7, 3.8%. So it's under 4%. But we've got increasing demand. Demand is about 4 or 5% a year going up. And we're living longer with more complex problems. I mean, people used to die of diabetes. People used to die of COPD. People used to die of all kinds of stuff that today you find people with 3 or 4 of these long-term conditions and they live into their 80s and 90s.
You say it's a long-term condition and you know those baby boomers are living longer. That's the bigger...
My hope is, because the baby boomers have had a better diet, no war, and a lot of them won't have smoked, my hope is that they'll be healthier and there will be less demands on the NHS. But it's about really, it's not adding years to life, it's about adding life to years. It's the last 5 years of your life, the extent to which they can be healthier. You know, we are kind of kicking life expectancy down the road, kicking the can down the road, but it's, you know, what are we storing up in the future? Now, if you look at long-term conditions, I mean, let me take diabetes, for example. It's perfectly possible to maintain a diabetic very safely using an app, using a call centre, and helping them to look after themselves. They become an expert in diabetes.
The advances in wearable technology for diabetes.
We can do all that, but you see, there's no point in doing that if all I connect with is my GP practice, because the GP are going to say, no, really, no, you know, it's better if you ring up for an appointment because we can put that off, you know. So that's the pinch point. That's how they manage demand. That's why you can't get an appointment for a fortnight in many cases. So, you know, that's the way it works. So what we have to do, I think, is what I see in the future anyway, are call centres, regional call centres dealing with a population of, say, 5 million people, where you can get an algorithm properly worked, and where, you know, you do your little test every day, you do it at home, and then you send it in, digitise it, send it. It's perfectly possible we can do that now. And, you know, the algorithm flags up red and somebody looks at it and they give me a ring and they say, Roy, you okay? You're tested. And I say, well, I've had flu-like symptoms for a week. I don't feel too good. They say, well, why don't you go and see the specialist nurse, the diabetes nurse, not the GP practice, so they will be someplace else. Or I might say, well, you know, I went out with the guys at a Ruby last night and drank 16 pints, and they would say, well, calm down, you know. So
that might relieve a bit of pressure on the GPs as well.
Well, it will. I think
the GP surgeries, as you say, getting appointments and things like that. I think everyone.
Look, there are 3.5 million people with diabetes. I mean, I don't know what way we're majoring on diabetes, and I'm sorry if you feel I'm getting at you, but 3.5 million. It will be 5 million by 2025. Now, there is no way that the GPs, with the best will in the world, can look after 5 million diabetics. We have to find another way of doing it. And when you look at artificial intelligence, which Babylon uses, okay, it's in the early stages of development, but artificial intelligence gets better the more you use it. The technologies that are wearable, the things that we can do, we have to stop thinking as the GP being the gatekeeper for everything. I think we need to redefine them as community physicians. They generally, it's not general practice anymore. It's specialist community physicians that I think we want. And maybe, they don't have practices in premises. Maybe they're in supermarkets. Maybe they're in a shop in the high street. Maybe we just change the whole thing. Because if you go to some practices, the biggest part of the square foot of the practice is made up with keeping medical records. These blooming, Lloyd George records. So when and they don't need to. I mean, I don't know why they're not just shifted out the GP and put in a warehouse on the edge of town. If they ever want them, you can go and get them. But so if you look at what we can do digitally, I was in Australia earlier this year. It's very interesting what's happening in Australia. By Christmas, every Australian citizen who wants it will have a PIN number. And that PIN number will give access to their medical record. So if I come and see you as my GP, you'll say, "Hi Roy, okay, what's wrong?" You say, "I've got a lump on my thing," or whatever, "this hurts." And you say, "Fine, okay, let's have a look at your record." I give my PIN number to you to access my record. Now, it works just like the banks. If I come into your shop and I say, "I have a pair of socks," you say, "Fine, here are the socks, give me access to your bank account so I can take out 15 quid or whatever it is." So I put my PIN number in a little thing and you get the money. In Australia, go and see the doctor, I put my PIN number in a little thing, you get access to my records. You do that, you revolutionise everything.
Yeah.
And the guy that did that is a guy called Tim Kelsey, who used to run the digital program here, care.data, and ran into all kinds of aggravation over data.
Supposed to get digital records, weren't they?
Yeah, data protection and all the rest of it, and it just all kind of fell out of bed. But it's all there to do. So when you look at the future, it's not about Mr. Spock and his wonder thing, fixing you up. It's about actually using the technologies we've got. If anything, we don't need any more technology.
I suppose you're saying, the NHS Fab NHS stuff. Sorry, that you're showing that best practice. It's almost like showing that best practice, around the world as well. The innovation and the stuff. You don't have to go and spend loads and loads and get loads of apps, but there's some simple solutions.
Yeah, we can track who gets onto the website, and we have people from all over the world.
I bet.
Yeah, I mean, we really do. I mean, and not just the English-speaking world. We have a huge global reach.
The NHS is respected throughout the world. We do lots of work in America, and they still think it's great. If they're going to have a child, for example, they said the amount of money you pay.
Yes.
They still can't believe you can just go in and there's a level of service you get for absolutely nothing.
We syndicate our risks, don't we? We say, we take off the shoulders of working people the worry of illness, accidents, disease, maternity. We all put a few quid in the tin, and when we need it, it's there. And with any luck, you put a few quid in the tin and you never take anything out. Other people, they put a few quid in the tin and they'll take a lot out. It's life's chances. Yeah. It's happenstance. And that's what the NHS does. It's a great system. Socialised medicine, it's a great system. It's not universally the best outcomes in the world, and we've got a lot to learn and a lot to do, and it's been through a difficult time, but it's a fabulous system.
We agree. You did mention about the Health and Social Care Act. We haven't got much more time, but I'd love to hear your thoughts on it.
We're going to need a lot more time. Look, Andrew Lansley's idea was to have a distributed leadership model, so there was nobody actually in charge. It will be run very much like the Bank of England's monetary board, And his idea was that the Secretary of State would step back, and he would give direction via an annual mandate, which would be like a shopping list. So, okay, guys, well, I think you should do this lot. And then NHS England, who was responsible for primary care and general direction, would commission it in primary care. its predecessors were Monitor and the Trust Development Authority, or whoever it was. But NHSI would fundamentally run the secondary care element of it. NHS Health Education England, they would make sure there were enough trained people, and NHS Digital would sort out all the bobble hat stuff, and it would actually put these services outside the reach of politicians in the day-to-day. Well, of course, what happened is the whole thing imploded. On top of that, we had CCGs invented to replace the primary care trusts. We had about 150 primary care trusts replaced by 212 CCGs, as it was at the time. Tiny organisations without enough management reach and experience. I mean, where would you go and find 212 really good chief executives with experience of healthcare to run the commissioning for their populations? You couldn't do it. GPs had a go at it, but they're not managers, and they did it in their spare time. It wasn't a day job. So it was a disaster, and we said it was a disaster. I just wrote myself to a standstill saying don't do it. The only two organisations who said it was a good idea was the Royal College of Surgeons, and that was because the Act envisaged hospitals doing more private practice. So you can draw your own conclusions there. And the National Association of Primary Care, who Lansley had become close to it when he was in opposition. And he had really courted the National Association of Primary Care. And when the reforms came out, originally the NAPC, National Association of Primary Care, supported them, but today I think they've realised really that what Lansley talked about when he was in opposition never actually became a reality. Now, halfway through the implementation process, the Prime Minister made a speech at Ealing Hospital where he called a halt, a pause. And Steve Field, who was a GP, led an inquiry into whether or not we should go ahead with it. The Field report was a soft report, really. It was a waste of time because he really didn't want to take on the government, I don't think. Everybody I know said this is a bad idea, please don't do it. They did it. Now what's happening is everybody says it's a bad idea, how do we undo it? And Simon Stevens now is trying to move NHSI and NHSE together as much as they can within the law. NHSE is moving and the number of CCGs is dwindling, they're merging and they're disappearing and all of that. And we're trying to get back to some kind of properly organised national thing, because you've got head office, you've got regional office and local offices, and that's how it works. How the army works, it's how Marks and Spencer's work, it's how the NHS has to work. So we've wasted a lot of money, and it's worse because it came at a time of austerity. It was after 2010, there was no money, there was a cull of managers, mood was very, very poor, and we're only now really starting to recover. So it was a really, really bad experience, and I can't find anybody now who voted for it in Westminster who says they voted for it at Westminster. So there you are.
We did meet an MP, Eleanor Smith from Wolverhampton, and she's put in a new bill called the NHS bill that looks to reverse all that.
Yes. Well, that's the important point to make. Because of Brexit, parliamentary time is now very scarce, and the NHS bill is 360 pages. Well, the NHS Act was 360 pages. Unpicking it is an enormous piece of re-legislating to go back to the status quo. They're trying to do it with a single line bill, and I think they're trying to say let's go back to where we were before 2012, and there might be a neat parliamentary trick that they can pull off there, because there are difficulties with NHSI and E, the two principal organisations working together. There are issues over governance and money and all the rest, and they're very anxious not to be caught out, to be behaving in a sort of quasi illegal, so it's a really tricky thing for them to do.
Roy, look, thanks so much for your time. We really, really appreciate it. I think we could have talked to you for hours. Is there any message you'd like to give to our nurses that are all watching?
Yes, I mean, I don't want you to think I've been, I hope you don't think I've been unduly pessimistic about nursing, but I want to be realistic, because I think if you care about something, and I do care about nursing, I think you've got to have these frank conversations. You have to roll your sleeves up and say, okay, fine, is what we're doing okay? if we always do what we always do, we'll always get what we've got, and is what we've got what we want. And I think it's probably true to say that I'm not at all saying there needs to be a revision in nursing, but I do think we have to understand the role of the digital nurse, the role of the training of nurses, and the pathway into nursing. And I think if we get those three things right, then primarily we'll have enough nurses, and secondly, more people will realise that being a nurse is a fabulous career. And for those nurses of you who are watching this, I wish you well in your career. If you're just starting out in nursing, good luck. And if you're thinking of becoming a nurse, I tell you what, it's a great job.
Thank you, Roy. Thank you everyone for watching The Voice of Nursing. Thank you to our nurses as always, our healthcare assistants, our doctors and our support workers. We'll catch up with you soon.